Good morning and welcome. This is Dr. Troy Adams. We're delighted to have you with us today. I'd like to toss to my business partner, Dr. Stephen Aldana, with a brief introduction and also an announcement about an upcoming webinar we're doing in January. Steve? Oh, goodness, we seem to have lost Steve. So I will just say we're really glad to have you today on this webinar. And we know that it's December. We know that this is open enrollment time. It's a really busy period. But we've got some really good information we're happy to share with you today about health risk appraisals. It's a relatively germane topic, but boy, it is one that is really important because it's easy for a health risk appraisal to go missing in action. And I think there we have Steve. Steve, are you there?
Troy, can you hear me all right?
Yes.
I don't know what it was, but technology got the best of us on that one. Um, I apologize for that. I wanted to do a brief introduction of Dr. Adams. I know most of you know him. Troy, I didn't hear what you might have said before, but Dr. Adams is the business partner. He's the director of operations here at WellSteps, the vice president of operations. He's the reason why our solutions work so well. He got his PhD from UT Austin, University of Texas at Austin. Then he did some work at Arizona State and Oklahoma State before he joined me to create WellSteps. He's a consultant, an author. He's a speaker all across the United States. And he's just been a great partner. A couple of things you may not know about Dr. Adams. First off, he's a huge, huge BYU fan of all sports, of all varieties, of all genders, which is commendable. And he has a wonderful mutt lap dog, a one-eyed lap dog named Winky. And I hear we're going to get a little story about Winky. Just a few logistics before I turn it over to Troy. All of your phones have been muted, so you won't be able to speak on your phone or microphone. But in the GoToWebinar control panel on the right-hand side of your panel, there's a questions link, and you can type any question you want. We have Ryan Isaacson with WellSteps behind the scenes going through your questions, any type of questions you might have. We'll get to those later in the presentation. All of the slides today have been posted at wellsteps.com. Just click on our webinars link and you can get a copy of the slides and a copy of the recording of the video shortly after the webinar is over. Feel free to ask any questions about any of this topic. The more interaction we have, it's always the better. We have about 400 people signed up today, so it's a great group. And with that, I want to turn it over to Dr. Adams. Good morning.
Thanks very much, Steve. It's good that that you won the battle against technology. It is a constant battle. So here we go. Let's just go ahead and dive right in. Here's where we're going to go today. First of all, I'd like to give you a bit of a background on the HRA. Now, we've done this, we've kind of hit this topic about a year and a half ago, so I'm going to make this brief. I just want to remind you about the origin of risk factors and the development of the health risk appraisal. I also want to remind you of the three purposes of an HRA really quickly and talk about the relative importance of each. And then, most importantly, I want to discuss the way that an HRA can go missing in action and how you can keep it from doing so. That's really what we're about today, is helping solve problems that pop up in operations of wellness programs. So backgrounds of risk factors. Basically, a risk factor is something that increases the odds of a poor health outcome. And we're really focused on poor health outcomes in terms of risk reduction. Risk factors were most notably used by the life insurance industry in the late 1800s to manage financial risk. That's really kind of the origin of everything, right? If it's all about money, they used risk factors to, first of all, select healthy clients and exclude unhealthy ones. Isn't that interesting? And then later, they realized they were missing a substantial part of a market, and so they used risk factors to risk rate those who did things that increased risk of premature death. So really, really dangerous things like, I don't know, hot air ballooning. Boy, that's scandalous. But that was a really dangerous thing back in the day because we didn't know much about hot air ballooning. I just listened to a story about hot air ballooning, and back in the day, if you went up, nobody knew whether you were going to come down or not, or if you did come down, where you would land. Basically, hot air ballooning is how early scientists discovered the thickness of the atmosphere. There's an interesting story about two guys who went up in a helium balloon until they passed out at just over 30,000 feet. And we didn't know that. Nobody really knew that. And one of the guys managed to grip the rope in his teeth, the one that let the helium out before he fell over. So they came down and lived to tell the tale. But that used to be really dangerous. Now, not so much. Today, people who do base jumping or wrestle anacondas, now they would probably pay higher life insurance rates. The idea is that risk factors are being measured because risk factors increase the odds of being sick or dead. And those things are important to understand because they allow the insurance companies to charge different rates, much like we do with it's why I pay so much for one of my cars because I've got a 17-year-old son. Risk rating. It's basically the same idea. All right. So here's just for your curiosity some examples of early risk factors. Albumin. Albumin in the urine is a risk factor for kidney disease. That's one of the things the life insurance industry measured. Also, data told them that the obese had a mortality rate that was 41% higher, even though that was not the commonly held belief at the time. We're talking about the late 1800s. You're bigger, you're more robust, you were healthier, but the data did not agree. High blood pressure was identified as a risk factor for early mortality. In fact, it was a 1925 life insurance study of over 700,000 people that essentially led to the high blood pressure standard of 140/90 that we still use today. It's nearly 100 years ago. Also, chest x-rays for tuberculosis and ECGs for heart disease were also innovated and largely helped to develop by the life insurance industry. So there you go, early risk factor examples. Now, we talked about negative outcomes. We want to eliminate negative health-related outcomes. That's one reason why we do wellness. It's not the only reason, but it is one reason. What we've ultimately learned from the study of risk factors is that they cause chronic disease. But it's important to note that they essentially are caused by unhealthy lifestyle, which plain and simply is the root of the problem. So when you ask the question, what causes negative outcomes, you really got to go back to unhealthy behaviors. So we're going to focus on that. So really quickly, a background of the health risk appraisal. Now, what I did, I have done a one-page bullet-pointed PDF of the entire historical background of the HRA with some key milestones and touch points and how we kind of use that in our version of the health risk appraisal, which we call a personal health assessment. And I posted that on our webinars page right next to the slides for this webinar. So, and I'll show you how to get those here in a minute. But what I'm going to do is just really high level go over the background of the HRA so we're all on the same page. So here's the deal. Lifestyle. First of all, the Surgeon General's office began to realize the degree to which lifestyle impacted outcomes. So the Framingham study was launched. They wanted to explore this relationship. The study began in 1948, 3 years after the end of World War II. There were originally about 5,200 adult subjects from Framingham, Massachusetts. Now the study is in its third generation of participants. This is one of the most fabulous studies that's ever happened in terms of our understanding of lifestyle factors and the impact on health outcomes. So one of the study needs was a standardized survey to assess risks. You could only collect so much biometric data, and so they wanted us to understand what people kind of things that they did. Did they smoke? Were they physically active, etc. So the survey asked questions about lifestyle factors that were known to influence sickness and death. Now, the big fancy words for that are morbidity and mortality. It's the same thing. So the Framingham Risk Survey was really the first health risk appraisal. Now, eventually, the CDC got this survey, and they, by the time the the 80s rolled around, they developed computer software which they gave to state departments of health, among others. I in fact worked in a fitness center in beginning in 1987, and we had that software with the computer, and we did health risk appraisals for our members that long ago. So it's been around for quite a while. Now, the state departments of health realized that in the 80s, think about your computer, if you were alive then or used a computer in the 80s, think about trying to cart that bad boy around to collect data. Holy cow. It was really difficult to collect data via computer. So what they did is they developed a basic survey and they adapted it for the phone. And that's still how they collect data on population health risks today. It's called the Behavioral Risk Factor Surveillance System. You can actually go on the CDC website and see all the questions for every single year. It's administered every other year. And this is the primary tool that we use to develop our personal health assessment at WellSteps was the questions from the Behavioral Risk Factor Surveillance System. So the state departments has figured out a way they can collect data for public health research. And then the HRA has since been adapted for computer use as computers have become more prevalent. And of course, the internet changed everything, and now they're smartphone based. So the HRA is in a state of continual evolution. Bada boom, 30,000 feet. There you go. That's the background of the HRA. Again, you can get the PDF that explains in more detail some of the milestones that I've kind of left out about the HRA that I think are pretty cool. All right, so just a reminder really quickly, there are only three purposes of an HRA. These are actually three primary purposes. One is to raise health awareness among employees. Oh, I didn't know I was at risk for this. I didn't know that this was a problem. Implication being it should motivate you to change. It does sometimes it doesn't. The second is to plan interventions. You get data when a personal health assessment or an HRA is completed that helps you plan something to do about it. And the third is it is a great way to collect baseline data so that you can evaluate change. Now remember, raising awareness is part of the secret wellness sauce that we often talk about. This is a slide that you perhaps have seen before, but it's really important. So the critical thing to remember about HRA data is, again, that population data can be gathered that will assist in the planning of interventions that motivate, that provide tools and skills people need to change. And sometimes people don't change because they don't have the necessary tools. Maybe they don't have running shoes, or they don't have a stroller they can put their child in to go on a walk. Those are tools. They don't have the skills. They don't know what to do with an acorn squash once they get it home. They don't know how to cook correctly. So those are skills that people need, and those are activities that wellness programs ought to be engaged in. And they also, this data can help identify things that need to be changed in worksite culture by setting policies or adjusting features of the work environment, things like vending machines and so forth. So that's the secret sauce. The awareness and education is a relatively small part of that whole thing. But it's also important to remember with these purposes, good baseline data is valuable in helping to measure progress from point A to point B and so forth. So in perspective, you could rank the importance of a health risk appraisal a little bit like this. If raising awareness is sort of important, planning interventions is huge, perhaps the most important thing, followed by evaluate change. But unfortunately, too many professionals are happy to use the HRA as an intervention without really going any further. And unfortunately, that's not the purpose for which it was designed. So important stuff. Let's talk about ways that an HRA can go missing in action and what you can do about it. All right. First of all, your HRA can go missing in action because it breaks the law. Now, what law are we talking about? Well, primarily we're talking about federal non-discrimination laws. For example, GINA, the genetic law, says you can't discriminate based on genetic information, which, by the way, includes family history information from a health risk appraisal. That's the ruling. Can't break the law. So remember, next slide, I'm going to tell you what to do about this. What about the American with Disabilities Act? We get that question an awful lot. So here's what you need to know, really simply. The ADA, in a letter dated in January of 2013, stated, and I quote, that disability-related inquiries and medical examinations, which includes HRAs and biometric screenings, are permitted as part of a voluntary wellness program, end quote. So the question becomes, what's voluntary? Well, it's interesting that the ADA has no stated position on whether and to what extent a reward amounts to a requirement to participate. They also have no position on whether withholding the reward from non-participants constitutes a penalty. Interesting. However, the new Affordable Care Act regulations do both. They both specify, define, and then they give a percentage. They say that a reward or penalty is one and the same, and in their language, they call, if it's a reward, you give somebody money for doing something, or a penalty, there's a tariff or a fee if you don't comply. Maybe you smoke, or you're not physically active, whatever. They call both of those a reward because there's a financial outcome in both cases. So they've simplified it. They also say that effective 1/1/2014, you can reward an employee up to 30% of the total cost of healthcare premiums, and that means the employer plus the employee portion. My guess, it's a guess, but my guess is that ultimately American with Disabilities Act will amend. They'll adopt the new regs from the Affordable Care Act, but who really knows? For right now, there are no, that has not, those things have not been defined by the Disability Act. But I think in the interim, it's good to follow the Affordable Care Act guidelines. Now, so what can you do about that? I'm going to show you in a second a tool that we've provided that will help you follow all of those regulations. But first, let me address just one more issue. So what if you use a free HRA from your carrier? How can that break the law? Well, the law says they cannot use your data, individual data, to raise your individual rates. However, you're in a pool of some sort. Either it's an employer pool or it's a small business pool. You're in a pool that is risk rated. They can put you and your company in a pool that pays higher rates. So just that's kind of an aside, but I wanted to mention that because we also get asked that question quite a bit. So again, what can you do to keep your HRA from breaking the law? Well, here's what you can do. Here's ways to get the most out of your HRA. First of all, I would, if you can, if you've got a health risk appraisal that has family history questions on it, like how many people in your family had heart disease, I'd take those off if you could, or I'd find one that doesn't ask family history questions. That way you'll be well within the law. That's for Gina. Now, for the Affordable Care Act, I would recommend tying rewards to completion, not to answers that are on the health risk appraisal. Here's why. Because the HRA only serves to raise awareness, is not really that important in terms of changing behavior. It's important in planning behavior change activities, but it doesn't do much to change behavior. You really want to make sure there's no penalty based on how people respond to the questions. What you want is accurate baseline data. So if you tie the incentive to the completion and not to items on the health risk appraisal, then you're more likely to get accurate data. So that's what I would do to keep my health risk appraisal from going missing in action. Another thing I would make sure is for the ADA, make sure that the HRA and the associated wellness program are all part of the benefits plan, and that's pretty simple to do. In open enrollment, every broker that I know, well, a lot of brokers put together plan documents to describe here's what's in your plan. Your vision care is this. Your dental benefits are this. All you have to do is integrate the wellness program into those documents, and that's what a federal judge said, who ruled in favor of a county wellness program in Florida. The plaintiff said, well, the HRA violated American with Disabilities Act because it asked me about things like depression and alcohol consumption. Well, the judge said, no, it doesn't. It's part of a wellness program because, look, it's right here in these plan documents. So that's one thing that you can do to protect yourself there. Make sure that you describe the wellness program in the plan documents, and boom, you're good. All right, so where can you find that tool that I was talking about? Right here, you go to our webpage, Wellness Tools. Just click right there, and there's a tool called the Wellness Compliance Checker. If you're really concerned about being compliant with all the privacy or non-discrimination laws that I just described, use the Wellness Compliance Checker, which, by the way, will be updated. We're at the very end of 2013, so that it's accurate with 2014 data because there's some stuff changing. Okay, and it's free. So here's another way that your HRA can go missing in action. It can't be branded. It can't be tailored or branded. One of the things that I've learned in my years and years of working with people who are trying to improve their health, and also with companies in a consulting process, that companies, just like people, have personalities. And sometimes a question is, boy, it's a huge deal, and it violates a social norm in companies, and it causes problems. So sometimes removing or adding the question is necessary for any of several reasons. If an HRA can't be tweaked, it's not all that good, because we don't want to step on toes. In fact, not being able to tailor a question or two can often create more problems. So, um, again, we're going to talk about things that can be done to fix that. But let's mention briefly also that lots of companies spend tons of money to develop their brand, including their logo. It's part of their image. So, in my opinion, the company logo should show up somewhere because it suggests partnership to the employee. I think that's pretty huge. So, here's ways you can get the most out of your HRA. Expect flexibility with questions and branding. I'm going to give you some examples here. We have a wonderful customer in Australia who uses our health risk appraisal, which again we call the PHA. On our version, the US version, we include a question about seat belts and about chewing tobacco. The guy we work with in Australia, Ken, he said, "Look, we all wear seat belts down here, and nobody chews tobacco. It's really a nasty habit. We don't know what you Americans are doing up there. We don't know why you don't wear your seatbelts and why you're sticking that nasty stuff in your mouth. We really don't need to ask those questions. In fact, people would be offended if we did." So we said, no problem. We figured out a way to remove those two questions, and they also wanted to add a question or two, and that really adapted it to that culture, which is clearly different than the U.S. culture. It should not be that hard. Anyone should be able to help you do that. We have another customer who has wisely and generously, very generously, included their retirees in their wellness program. A lot of people don't do that. We had 3 questions that ask about work related issues, and we got several emails from retirees that said, "Nanny, nanny, doo doo. I don't work anymore. Thank you very much. But by the way, this question doesn't apply to me." So what we really needed to tailor the wording of the question so that it became, and what we did is we just added a response option that said does not apply. That way we knew that they were, we have another way of knowing that they're retirees, but that gave them an answer that they could provide. Here's an example of branding I want to share with you. So we had a customer. It was very important that they have a logo for their wellness program, and they wanted that to show up in a splash image on a landing page where we help people register. And so we did this for them, and then they also had a logo for the overall organization that we put in their employee dashboard. The default for us is we include a logo and a CEO image. In this slide, you see the logo there on the left, and you see an image of Steve, who's our CEO. And we found that sometimes companies want the logo or the CEO image, and sometimes they don't want either. So here's a story about Winky. We pretty early on I had shared a photo of my dog with his one eye to make a point, and these customers saw it and they said, and I'm going to quote, they said, "Our CEO is ugly. Can you use the photo of your dog instead?" So we put Winky right up there where you see Steve's picture, and they all agreed it was a dramatic improvement. So there you go. Some of you have seen this before: health grade, health teach behavior, and then there's the feedback. Okay, so another way your health risk appraisal can go missing in action. It cannot reach the non-English or the non-webs. Non-webs, that's what we call people who do not or will not connect to the internet. So many companies have employees who don't speak English well enough to complete an HRA without assistance. So you might think, and I've heard this thought expressed before, if you're in America, you should speak English. Well, it's not that simple. I think maybe because I lived in a country where I spoke French every day for 2 years has made me a little bit more sensitive. But there are some companies that will never not have Spanish speaking workers. It's just a fact. So it's easier to adapt an HRA to Spanish than to try to get people who are taking the HRA to learn a different language. Let me say that again. It's easier to adapt an HRA than to adapt people. And we're trying to help people. There also, I'm going to point out there are some privacy issues. If you insist that Spanish speaking workers complete an HRA and you've got to have an English speaker sitting right there, that's an employee most often who's sitting there next to another employee who doesn't speak English that well. And now all of a sudden you've got sort of a violation of some privacy laws. So that can all be averted with the Spanish version. I'm going to show you a couple of simple tools that you can use to kind of solve this problem here in a second. Now, regarding the non-webs, those not connected to the internet, we've gotten really high penetration on the web in this country, but we've really stalled. We're at around 80% of Americans with web access, but there's a certain percentage of the population, not just seniors, who will never have or ever want access to the web. And in most cases, these are the people who need our help the most. So if an HRA can't reach these good people, it is missing in action. No other way to put it. So what do you do about it? Well, here are some ideas. You can just use a paper version of the health risk appraisal. Some people say, well, that's not as fancy. It's not as dazzling. Remember, you're collecting data. You're raising awareness a little bit, but what you really are after is that data to help you plan interventions. So once you have a paper version, what we did is we simply took our questions, we put them verbatim in the same order. We initially used Microsoft Word and we laid it out with a little fancier software, but it's really easy to do with Microsoft Word. Then you can, and then we went on, so we had a paper version in English. Once you've got it in English, you can translate it into other languages. And here's how we did that. So you can do this easily too for not that much money. We went on guru.com, G-U-R-U, there we go, guru.com, and we hired a Spanish translator to translate our questions and feedback. And luckily, we have a Spanish speaker on our staff, so that helped as well. We then created a Spanish HRA with the questions in the same exact order so we could enter the data. And I'll skip a few steps and involve our system, but ultimately we made it so that we could use the mail merge function available in Microsoft Word to create Spanish feedback. You can learn how to use Microsoft Word mail merge feature on YouTube really easily. It's not that complicated. All you need is Microsoft Word, Microsoft Excel, boom, you're good. Anyone could do this. We've done this for Portuguese as well, and Canadian French is in the works. So hopefully that helps a little bit. It should help you with your non-webs and also with your Spanish-speaking population. Here is another way your HRA can go missing in action. There's too many questions, and it's too darn hard to read. Steve and I have worked with more than one carrier, probably most of the carriers who have had expressed significant concerns that their participation rates were not that high with their HRA. We know of one carrier that has an HRA that takes about 45 minutes to complete. One executive we were talking to about this problem said, and I'm going to quote, this is a direct quote, he said, "It took me 45 minutes to complete that stupid HRA. It is just too damn long." Close quote. We agreed. We found that the completion rate is directly related to the length. I mean, the goal is data, right? So we want to make it short and easy to complete. It's huge because if you don't have data, you can't plan, you can't coach, you can't help people change. In my mind, there's no question that simpler on HRA length is better. One other thing, it's too hard to read. If people can't understand the questions, they're likely to walk away. You know why? Because nobody wants to feel stupid. And I say, if we insist on using $6 words in our health risk appraisals, shame on us. Shame on us. How dare we chase away people who need our help the most because we want everyone to think we're smart. Simpler is better. Simpler is always better. So there's a rule of thumb. Here's what you can do about that. If you can't complete the HRA in 10 minutes or less, it's too long. find another one or shorten up your HRA. You got to be able to complete that thing in 10 minutes or less. Um, and again, that's important because the length is a primary predictor of your completion rate. Data inaccuracies both can impact the validity of your subsequent plans. So as a minimum watermark, you want HRA completion rate to hit around 60%. And that's determined by a lot of things, incentives, but we found that the primary predictor really is length. So what about readability? Being able to understand the words you're reading. Here's a fun example. So in Microsoft Word, I turned on the readability statistics in the Microsoft Word spelling preferences. Anyone can do this. You want to make sure you're hitting around the 6th or 7th, no higher than the 8th grade reading level. What I did is I highlighted these two passages, then I ran a spell check. You get a grade level. I'm going to show you here in a second what it looks like of a selected passage. So please identify the response that most accurately reflects how frequently you utilize buttery gravies, coulis, or similar in your cuisine. This is a 12th grade reading level. This is what the report looks like. And down there at the bottom, there's a Flesch Kincaid grade level is 12.0. That means if you're a senior in high school, you can read it. But if you're not, you got to remember only about 30% of Americans graduate from college with the 4-year degree. So 12% is pretty, 12th grade is pretty darn ambitious. It needs to be simpler than that. If you're looking for HRAs, you can do this. You can do the same thing with the longest question. Just type it in Microsoft Word, turn on your readability statistics, and see how complex the question is. 8th grade should be the upper limit. Oh, here's a simpler version. This is a 2nd grade level. How often do you put butter in your food? Boom, simpler is better. All right, here's another way that an HRA can go missing in action. The feedback is same problem. It's unreadable. And one of the things we've noticed is there's no nudge to action. I think in marketing, they call it a call to action. We prefer to just call it a nudge to action. So I once helped a company, consulted with a company to help them develop a health questionnaire. This is probably, I don't know, 8 or 9 years ago. I was looped out of the feedback development process. And when I found out what they were doing, I was really glad because I heard one of the project team leaders say, quote, "We want to create feedback that is so thick, it thunks when it hits their kitchen counter." And I remember thinking, that would also make a nice thunk when it hits the recycle bin or the trash can, because something that thick is going to be overwhelming. Nobody's going to read it. Nobody's going to read it. So just like questions, the length of the feedback is a problem if you got stuff that's too long. Readability is also important. I always say that reading the feedback should take no longer than 5 minutes, and that's generous. 5 minutes is a long time. We live in a YouTube generation. People enjoy watching videos, not reading so much. So it's got to be really short and to the point. Remember, we're trying to help people improve their lives, so simpler is better. Also on this, talking about nudge to action, if we expect the HRA feedback alone to motivate people, we're living in a dream world. There was a study published in the American Journal of Health Promotion. Oh gosh, it's over a decade ago, but it's still really, really good data. And what I remember about it is it rated the effectiveness of 13 different types of health promotion or wellness programs. In their rating system, the most effective was 5 stars and the least effective was 1 star. The health risk appraisal was rated least effective, 1 star. So there has to be a nudge to action after the feedback is delivered. Otherwise, we're just using something that's kind of ineffective. We can increase the effectiveness beyond raising awareness if we nudge just a little bit. So it's something that reaches out and compels the user to change right after they've completed their HRA. So I'm going to share with you just a couple of examples, and then maybe at the end, some of you have some great examples that you've used that we've not thought of, and we welcome those in the feedback portion. So there's really 2 types of behavior change that we're trying to influence. One is health behavior change, and the other is screening behavior. Health behavior means I'm eating more fruits and vegetables, or I'm being more physically active. Screening behavior means I'm more consistent about doing the age, gender, and risk appropriate screenings that I ought to be doing. I want to mention both of these briefly. So first, let's talk about health behavior. So here's a well, first of all, here's a good way to test whether your feedback helps to nudge behavior change. Take your HRA as a healthy user and as an unhealthy user, and then read the feedback for both. Test how long it takes you to read it. If you're healthy, does the healthy feedback give you ideas to maintain and cross train? That's what it ought to do. Maintain and cross train. One of the biggest risks of healthy people not being healthy is that they get bored. To help prevent boredom, they need ideas to cross train. Even if it's eating, there you can apply the same principle. If you're an unhealthy user, does the unhealthy feedback give you ideas to improve and hope to change without shaming or blaming? Those are some emotional things we want to avoid. The whole guilt trip. We shouldn't use shaming or blaming. All right. Um, so here's a simple. Okay, we talked a little bit about screening behavior, like blood pressure screening, glucose screening. We'll talk about that in a second. But here's an idea based on evidence that goal setting is an effective strategy for changing dietary and physical activity behaviors. A really nice review of literature that said, hey, if you just have people set goals, they're likely to do better, like a lot better. We developed this tool called My Goal, and it's based on the notion that if you do something for 21 days, it becomes a habit. And so we provide goal suggestions immediately following HRA completion. Once a goal set, then the user gets a welcome email, then reminder to record progress emails at 7, 14, and 21 days. So it's a nudge, just a simple nudge right after they're done with their health risk appraisal to now let's set a goal and do something about it. Here's another idea that can be used if you've got health coaches or if you use health coaches, because health coaches can help set goals. And that's one of the things they ought to do. Help employees set and follow up on goals. So a company can do an HRA at open enrollment or maybe with kiosks. And when the employees come out of their open enrollment meetings, you have health coaches available immediately. And there's going to be a traffic flow problem because you're going to have more people than you're going to have health coaches. But you can have somebody there to set appointments and give phone numbers and whatnot so that the health coaches can call that day or the next day to immediately talk about the feedback and the goals, et cetera, and so forth. And I know that some people have done that. That's another way to nudge employees to change behavior in a moment of nudgeability, if that's a word. So what about screening behavior? Some of you know about the United States Preventive Services Task Force. It's a nonprofit group, not a government agency. They regularly review all screening recommendations, and with an eye on effectiveness and cost effectiveness, they make recommendations for age, gender, and risk appropriate health screenings. Sometimes groups do an HRA with biometric screening. And that's one way of doing it because that means everybody is getting the screens. But a more effective way is to have employees complete an HRA and then refer them to get screenings based on age, gender, and risk, just like the United States Preventive Services Task Force has set things up. It's the way that my doctor uses. So this is one way that we've done. We've got a little thing called screening reminder. It includes recommended screenings based on my age, gender, and risk. And it's got a little barcode down there on the bottom to make it easy to verify who actually visited the doctor. Verification of screens might be something you would do if this were maybe an outcomes-based wellness program. Some people want to do this, but they don't need the barcode, and that's fine. So here's one way of doing that. Here's another way an HRA can go missing in action. Reports take forever to get. And we'll need to talk about that a lot, but we've heard this from frustrated customers with previous HRA vendors. So imagine that your employees have mostly finished taking the HRA, and you're down with the idea that you need that data in order to plan and to assess impact, and you're anxiously waiting for an aggregate report so you can begin planning. But 1 week goes by, then 2, then 3, and I'm not making this up. We've heard these horror stories before. and you feel like this kid right here. Oh my gosh, can it get any worse? In this day and age, delay in getting your aggregate report is huge. It's a huge fail in my opinion because it slows down your ability to plan. You should be able to get your aggregate report anytime you want. It's not that hard in this day of an age of electronics, especially. So one way you can help improve the speed of accuracy of the speed of delivery, excuse me, of your aggregate reports is to include a payment if you're working with a vendor that is contingent on the receipt of that report. That will speed them up a little bit in terms of getting. Another way to do that is to say, hey, can you um, we want to see an aggregate report right now for a company for a sample company, and then start the clock running and see how long it takes them. If it takes them 3 weeks, then that's a good indication that's how long it's going to take. If you get the email that day, then you have a good understanding of how it's probably going to work with you too. So the HRA provider has to have some interest in getting you your report as soon as possible, and that's one of the strategies behind making a payment contingent on the receipt of that report. That's just one idea. Some of you may have other ideas or horror stories; those are okay too. Um, and this is the last way that your HRA can go missing in action. We'll have time for questions. Getting the data and understanding how to use it requires an immense amount of patience and might take a PhD or a ninja degree in Excel spreadsheets. I was a little too long to put there, so I just put getting the data requires patience. Now, so let me go over this. Sometimes an arrangement has been made for HRA data to be released to health coaches so employees can be contacted. I mean, that's easy to do. That just requires something called a business affiliate agreement that specifies that you're sharing confidential data, et cetera, and so on. It's pretty much a standard form. Um, but let me put it this way: promising to share data takes less than 10 seconds. Actually sharing the data, toss the watch and get a calendar. I've heard some very frustrated comments from wellness professionals just like this. Or when we asked for the data when my son was in junior high, we finally got it. He was driving and shaving. So let me say that you finally get the data, and your job is to figure out what it means so you can communicate with the right people in a timely fashion. There is something to be said for reaching out to those people who need help, who said they needed help, sooner rather than later, right? I knew of a group who took an HRA. There was a promise to share data with employees who were at risk and who were ready to change, but the vendor waited and waited and waited until about 11 months after the HRA was completed. There was a request for data. Vendor was waiting for this request all this time. The vendor kept their promise and delivered quickly, but happened to ask, well, what are you going to do with these data? The disease management vendor said, well, we're going to reach out and contact the high risk. And I was like, you realize that some of the high risk indicated that they were ready to change like 11 months ago, right? This is a fundamental problem. This ought to be more seamless. 11 months later, they may not be ready to change. So here's one thing that can be done with that. Use a smarter solution. Here's what I mean by that. You want to think about who will be contacted for disease management or health coaching based on which variables and which risk levels. Decide that ahead of time so that there's no fumbling around with the data if you wind up getting the data. For example, I know a lot of groups might contact employees for disease management if they're at high risk for blood pressure, glucose, or cholesterol. Some groups might decide also to contact those who are at medium, what the Eddington calls medium risk. So then you want to email them and invite them to opt in. So here are a couple of this is a smarter solution for helping you get to people who already need help. Decide which variables you're going to use and which risk levels you need ahead of time. Here's what we do. We've decided to use the medium and the high risk on 6 variables. Well, we're only going to invite those to an intervention or health coaching if they said they were ready to change on that specific risk variable. So if they said they didn't eat any vegetables, they had to also say, I'm ready to change that. If they didn't, then you can reach out to them, but you're likely not going to have as much effect or success. So they've got to be at risk, medium or high risk. They got to be ready to change, and they have to be willing to share their data with the health coach. What we've done is we built a system so that we can email that specific group of people at any time during the health assessment process. We can reach out with them, and then it works like this. So we shoot them a message inviting them, all of those people, to health coaching. There's a button that says, so they get the email, button that says register any email, so they can opt in. And as soon as they opt in, employee schedules an appointment, leaves us the best number so we can call them, and then the health coach calls them right back. So it's really 4 steps. They have to be at risk, they have to be ready, they have to be willing to share their data with the health coach, and then they have to opt in. What that functionally does is it reduces the size of the number of people who are getting coached. That winds up being cost effective for an employer, and a coaching intervention winds up being much more effective because you're dealing with people who are really ready to work. So um, and what this basically does, it eliminates that frustration of combing through the data trying to figure out who you should contact, because a smart system has done all the work on the back end. At any rate, sometimes people still want the data, but these days smarter solutions are not that hard to build. So with that said, we've talked today about ways your health risk appraisal can go missing in action, things that can be done to remedy that problem. And so that brings us to the point where we can take questions and comments. We welcome any and all.
Thanks, Troy. We do have some questions. I wanted to just preview those questions with one observation that we have seen in the health risk appraisal world for a long time. And early on, 15, 20 years ago, health risk appraisals were all the rage. They were the beginning step for every company wanting to do wellness. And there was an awful lot of marketing, and there still is, not as much. But we had the impression for a long time that if you had a health risk appraisal, you had a wellness program. I know you and I have talked for a long time that a health risk appraisal does not a wellness program make. And yet, I think there's still some of that residual lag from all of the pressure and emphasis on health risk appraisal. So you had mentioned in one of your slides the proper place for the health risk appraisal, and you vacillated somewhere between slightly effective on awareness and behavior change to really effective on data management and data collection. You still stand by that? Have you changed any of those opinions?
Based on everything I've seen, and no, I haven't. I think that by and large, the most primary, the best reason for collecting or using an HRA is to get data you need to plan an intervention. And that can be done with an aggregate report, which we mentioned a little bit earlier. I think some of the coaching interventions in the study that I mentioned, for example, it was a rating of 1 for a health risk appraisal as a standalone wellness program, like you mentioned. That rating actually increased to a 2 if what they called back then was counseling were also applied. So you can increase the effectiveness, but a health risk appraisal is never going to be a wellness program. It's always going to play a role, but it's probably never going. If you don't do anything after the fact, it's never going to elevate above maybe a 2 out of 5. That's my informed opinion.
Okay, we have some questions from our attendees today. One of them has to do with the fact that this is probably the least enjoyable part of a wellness program for employees is the health risk appraisal. Despite the vendor's efforts to make these things colorful and lively and easy to complete, most people still get a bad flavor in their mouth in this experience. And if wellness is supposed to be, motivational and fun, why is it we start a program with this very first thing that we do in almost every case is we throw this giant survey at them and say, let's have some fun. If that model is so bad for employees, what's an alternative? How do we get it in there without giving them a bad taste in their mouth from the very get-go?
Well, I would venture a guess that this question is the person who's asked this question has experienced problems with health risk appraisal length and understandability. So I talked about those things in the webinar. So I would encourage you to go back and look at the length. Length is one of those things that makes something inherently not fun. When you hear somebody take an HRA and it's like going to the doctor's office, they say, "Oh, that wasn't that bad," then you know you've kind of hit it. You scored a touchdown. That's why I mentioned suggested that an HRA to take it ought to be really, really, really short. And there's no reason we shouldn't be able to do that. Another way to make it more fun, and I see people. I don't know of really many companies that are doing this, but I know that the technology exists is to instead of linking people to long pages of written feedback, to link them to very brief, actionable tips that they can take immediately, and maybe even think about using some YouTube videos or some videos to provide some. Yeah, we live in a YouTube generation. People don't read emails anymore. They'll read an embedded email, or they'll watch an embedded video, though, nine times out of 10. So I think both those things can make an HRA more fun. Make sure it's short. Make sure that people can understand the feedback, and think about other ways to share feedback than a 50-page report.
Doug has a great question. He says, can you comment on any strategies about keeping the health risk appraisal fresh? After using the same vendor for many years, it started to become kind of stale, giving the, in participants are giving the same information over and over again. And related to that, what's the proper frequency to give a health risk appraisal to your group? Do we do this every year regardless? Do we do it every 3 years? I mean, what's the ideal frequency to get the maximum out of this thing?
Well, let me address the second question first about the frequency. A lot of that depends on what you're using. What is the reason for which you're using your health risk appraisal? If it's part of an outcome-based wellness program, and again, I don't think it should be. I think that any incentive ought to be on just completing it, which is by definition not an outcome-based thing according to the Affordable Care Act, because then you'll get more data and you'll get better, more accurate data. If that's the reason you're using it, then you sort of have to do it every year because that's how benefit plans roll. And most of the experts like D. Eddington recommend once a year. I've heard people say, well, we want to have them complete. We want to have employees complete the health risk appraisal every 3 months. And I scream and run out of the room. That's just too much. I've also heard some experts say, you know what, why not every 2 years? I don't think that's a bad idea. So you sort of have to answer that question for yourself. How are we using it? If it's in a program where it's tied to benefits, that maybe you need to use it once a year as sort of a touchstone. If not, then there's no reason why you couldn't use it every other year. Now, the other question you had was about freshness. In the vendor search process, you ought to ask about uh, two things. First of all, what is the rubric or the template for creating the feedback? And then you should read some of the sample feedback, and then you ought to ask this question: how often is this feedback updated or edited? And both of I think every maybe 3 or 4 years, and editing feedback is an awful lot of work. And I think 3 or 4 years is an acceptable duration during during the editing process. So I hope that helps, Doug.
Jan has asked a question, and she and I are debating on what we think we heard you say. We're wondering about requiring employees to do a health risk appraisal or biometric screening in order to qualify for their health plan. And the discussion was, did we hear from you correctly that that was illegal? And I've assured her that it's not, but we need to clarify your statements on requiring a health risk appraisal and biometric screening as a criteria for uh, open enrollment or qualification to get a benefit, usually a healthcare benefit.
Um, well, I can recall talking about that in a previous webinar. But I don't recall mentioning anything about that in this particular webinar. But I'm going to agree with you, Steve. It's not illegal to use an HRA requirement or biometric screening for participation in a wellness program or qualification for a benefits plan. But that's a really complicated question. What I'm going to do is refer you to our webinars page. Go to Well Steps, click on the webinars page, and there's a whole webinar on. I forgot what the title is, Steve, but It's about HIPAA, GINA, ERISA. We recently did it.
HIPAA, GINA, ERISA, oh my.
There's that one, and then we did one on the Affordable Care Act where I think we mentioned we talked about a lot of that thing. So that was the Affordable Care Act. The Affordable Care Act, what you need to know. That was done I think 2 or 3 months ago. So I would go and watch that webinar, and then we go over that in detail.
Jessica has a good question. They have some of her population that is illiterate, that they're having a hard time, reading and going through written materials. What options do they have to help those few individuals complete a health risk appraisal? You mentioned, sitting side by side. What could possibly be done to help those few individuals get their information down?
Okay, I can think of two things. First of all, if you work with a third party HRA vendor, then I would ask the third party HRA vendor to have somebody there to help the people who are illiterate complete the health risk appraisal using a paper form. Using a third party vendor will basically protect the employer from later discrimination claims. And so that's related to the second thing I want to kind of bring up. Let's say that you decide that you're going to use an employee, maybe somebody in human resources or wellness program, to sit down next to the people who have literacy problems, and you're going to help them complete the health risk appraisal. As an employee of the same company, now you have knowledge about their risks, and most likely they are not going to come back and accuse you of anything. But really slick attorneys can convince them that them and all of their coworkers should accuse you of something, whether you did anything wrong or not. And I've said before that if you're in court, whether you deserve to be there or not, you're still in court, and it's no fun. So a person you sit next to could get fired for any number of reasons. The lawyer could find them and say, you didn't get fired because you never showed up to work. You got fired because you have high blood pressure. Look, they've got this information, and we're going to go to court and we're going to sue you. So that's a caution I would have. And I really don't know how you get around that, except for unless you provide some sort of simple form that then you would also have to explain to them. This form says I have permission to sit here next to you and help you answer these questions, and I'm going to look away while you circle the appropriate responses. And though if you do that, you have a form that protects you, and you make sure you don't see what they're circling, and you maybe have them fold up their responses and put in an envelope. You just have to be really, really careful about that. I hope I maybe over answered that question a little bit, but that's a great question.
If you could go to our next slide, while I remind all of our listeners that all of the slides and this recording have been posted at wellsteps.com on the webinars link. So everything we've talked about today, any of the ancillaries, the materials themselves are all available for you to use any way you'd like. Wellsteps.com, go to the webinars link, and you can see all the webinars that are posted there, which brings us to next month in January, the end of the month. We're really going to be talking about what I think is one of the more important reasons why we do all this, and that is, what's the impact of wellness on productivity? What do we really know? How is wellness connected to presenteeism, absenteeism? How is it connected? What evidence do we have that says that wellness programs can improve operational efficiencies and can improve the bottom line outside of the impact on healthcare costs? The reason that's important is because the rest of the world has socialized medicine. They do wellness for all the other reasons except healthcare costs. And as more and more individuals get thrown into the exchanges to get their healthcare coverage, that means that there's less of a healthcare cost reason for employers to do this. So what's the real benefit from productivity? That's the future. I'll be doing a meeting in Toronto in a couple of months. 500 employers will get together to talk about wellness. All of them are there for reasons other than healthcare costs. That brings us to productivity. And we encourage you all to come. Troy, thank you all very much. And everybody have a great weekend.